Hi, everyone. Welcome to the last event of 2021 Medicine in the Backyard season. My name is Kunga Wangmo Upshaw, and I'm the acting director of the Newport Beach Public Library Foundation. Thank you for inviting us into your homes this evening. Medicine in the Backyard is made possible by generous sponsor Mike and Polly Smith, UCI Health, and dedicated foundation members. Thank you all for going above and beyond to make our programs possible and to help us fulfill the Foundation's mission of providing funds to purchase valuable analog and digital resources for the library. You make our library card a powerful tool for everyone who wields it. To find out more about the Foundation and how to support the Newport Beach Library, please visit our new website at nbplf.foundation. So now what you need to know about this program is that we're recording it, and if you want to ask a question, please use the Q&A box at the bottom of your screen. Now I'm pleased to introduce our speaker, Dr. Stephen Yang. Dr. Yang is a fellowship-trained UCI Health orthopedic surgeon who specializes in adult reconstructive surgery and with a focus on primary and revision hip and knee replacement. He also holds a position as an assistant professor in the Department of Orthopedic Surgery at UCI School of Medicine. Dr. Stephen Yang earned his medical degree from the University of Miami's Miller School of Medicine in Miami, Florida. He completed a residency in orthopedic surgery at Harbor UCLA Medical Center in Torrance, California, followed by a fellowship in adult reconstructive surgery at Columbia University Medical Center in New York City. He holds a Master's of Science degree in molecular biology from UC San Diego, and as well as a Master's of Business Administration in Health Policy and Management from the University of Miami. So please welcome Dr. Stephen Yang, who will be talking about hip and knee replacement in 2021.
Great, thank you, Kunga. And thanks to the the Newport Beach Library Foundation and UCI Health Business Management for giving us this opportunity. So I had a little slide of all the places I've been, and you can probably tell I really know how to pick beautiful locations. So we'll skip this and get right into it. So what is arthritis? Arthritis is degeneration of cartilage in a joint that leads to pain. And this can happen and does happen in joints all throughout the body. Today, we're going to focus on the hip and the knee, but any joint that has cartilage can have arthritis. So for the most part, when we talk about arthritis, we generally refer to osteoarthritis. This is the arthritis that people get with time. This is what we consider wear and tear of the joints. And by and large, this is, as we get older, the type of arthritis that we tend to get. There are other types of arthritis, inflammatory arthritis, of which rheumatoid arthritis is one type. You can have post-traumatic arthritis from an injury, a fracture, dislocation, something like that. And there is arthritis secondary to rarer issues such as osteonecrosis, which can happen. But most of what we're going to be talking about as far as prevention of arthritis and treatment pertains to osteoarthritis. So who gets it? How often do people get it? This is data that came from a survey of a little over 10,000 people between the ages of 60 to 90. And you can see about 7% of people have symptomatic hip arthritis. So that's arthritis that causes enough pain that, is significant in the hip. And in the knee, it was somewhere around 12%. It's higher in women, and it increases with age. But it's a fairly significant number of our population as we age who gets arthritis. And the graph on the right comes from a study that basically shows how often people get treatment for arthritis, surgical treatment, so hip or knee replacement. And it follows largely the same trends as the prevalence of arthritis itself. So, one of the most common questions that I get is, how do we prevent arthritis? And really, this is if we could have it one way, this is what we want, is for no one to have to suffer from arthritis. And the things we can do from the beginning, the main two things are to maintain a healthy weight and to maintain strong muscles. And this can be done through what we generally call low impact exercises. So things like walking, cycling, swimming, elliptical, yoga, rowing, these are all great things to do. But the gist of it is that the more weight you can keep off of your joints, either by losing the weight or by strengthening the muscles to take the weight off of the joints themselves, the better that your joint health will be in the long run. So if you need treatment for arthritis, typically we start with what we call conservative treatment. So this is everything short of surgery. And the mainstays are medications. So the class of drugs that we call NSAIDs, non-steroidal anti-inflammatories. This is, ibuprofen, Motrin, naproxen, Aleve. They all fall into this class. And there are some prescription grade ones like meloxicam or Mobic, celecoxib or Celebrex. And these all function the same way. They decrease the inflammation, which is the primary cause of pain from arthritis. For the large part, these medicines are very safe to take. Most people can take them. There are some restrictions. People with kidney disease, people who are on strong blood thinners for various reasons. If you have atrial fibrillation or if you have some type of clot, can't take these medications. If you've had a history of gastric bypass or gastric ulcers, typically you can't take these as well. But by and large, it's a safe medication that most people can take, and it helps with pain. Physical therapy is the other mainstay of conservative treatment, and this is kind of ties back to maintaining strong muscles. This is doing conditioning exercises that strengthen the muscles around your hip and knee. Injections. There's a lot of data about injections. I'm going to talk mostly about two different types of injections: corticosteroids, which we've been using to treat arthritis for a long time. Corticosteroids are reliable. They provide relatively immediate relief, but this relief is temporary. So it's really a Band-Aid for the underlying issue, which is arthritis. The pain relief typically lasts anywhere between several weeks to several months. But as anyone who's had steroid injections repeatedly knows, the efficacy wanes over time. So the first one feels like a miracle, and then the second, third, fourth, fifth ones are less effective. We will sometimes use steroid injection to be diagnostic. If you have knee pain, hip pain, and back pain, a knee injection can, let's say it relieves 30% of your pain, then we can say about 30% of your overall pain is coming from your knee. The restrictions, by and large, steroid injections are very safe. There are some people who, some diabetics who are very sensitive to steroid, and it can cause a spike in the blood sugar. So that's one situation that we're a little bit more careful in. Another very common injection to do in the knee are, what are known as gel injections. So the gel is hyaluronic acid, and this is also called viscosupplementation. So there's a number of different formulations. There's 3-shot formulations, single-shot formulations, but they all contain the same chemical, and it's hyaluronic acid. So hyaluronic acid is really a lubricating substance in your joint. Our normal joints produce this acid. It's kind of like it has a consistency of egg white, and it acts to lubricate a normal joint. And in arthritis, or in an arthritic joint, less of this hyaluronic acid is made. And so the thought and the science behind these injections is that we inject the hyaluronic acid. It helps with lubrication in the knee or the hip. And, there's a lot of different numbers out there, but if you synthesize all of it, there's about a 60% response rate, meaning 60% of people who get a gel injection will say that they experience some relief in the pain. It's not perfect, obviously, and it's the big challenge is it's really difficult to predict who is going to be, in that 60%. Other challenges are that this is really only for early stage arthritis. If you have advanced arthritis, a lot of cartilage loss, if there are areas where you're bone on bone, this is really not going to be helpful. And also, unlike the steroid injection, it takes, typically several weeks for you to see any benefit. Other conservative treatments, bracing. I'm almost reluctant to talk about bracing, but it's part of our armamentarium. The way it works is by generally offloading the affected part of the knee. So this is depicted here as a medial offloader brace, and by and large, this is never a permanent solution, but it can be a temporizing measure. So patients generally, they find the brace is very cumbersome. Rarely are people enthusiastic about bracing as a long-term solution. I just have one slide on what I call alternative treatments. I'm sure many of you have heard of a lot of these. Um, Injection-wise, there are a number of different injections that people have tried for arthritis: PRP, or platelet-rich plasma, stem cell injections, prolotherapy. We could talk more about this, at length, but I will summarize and say that, in short, these have not been proven to be very effective for a large percentage of the population. There are people who have had stem cell injections, had PRP, who say that it's helped them. I've had patients myself who say that they've had it and helped, but by and large, it's not something that we generally recommend because it's not efficacious for most people. The basic science is promising. The ability of stem cells to heal is promising, but we're not at a point yet where I think we can harness that ability, and inject it into the knee and actually guide it to do what we want, unfortunately. People are often curious about topical ointments. CBD oil has been very popular recently. Again, there isn't great evidence to suggest that it helps for most people. Topical ointments really work by being absorbed through the skin, and there's many layers of tissue between the skin and your joint where you're asking this stuff to go. But having said that, some people feel some relief, and it's very low risk. So if CBD oil works for you, if anti-inflammatory ointments work for you, then I say I'm all for it. Similarly, for acupuncture and diet and supplementation, people ask a lot about glucosamine and chondroitin. There's, again, no evidence that it helps. There have been a number of studies comparing, diet and supplementation with glucosamine and chondroitin, and it doesn't seem to make a difference compared to standard treatment. So these are all things that, if I were to sum it up, I would say they are fine to try. They're low risk, but I don't routinely recommend them to everyone because I can't guarantee that, it helps. So if we're now talking about surgery, the question I get the most is when should I have surgery? When do I need surgery? And, the bottom line is you never need surgery, and the timing of surgery is really a very patient dependent thing. The things that I look for, when I meet a patient who's considering surgery is, have they exhausted non-operative treatments? You've tried weight loss, you've tried, anti-inflammatory medication, you've tried exercise, because there are some people who either can stave off the need for a joint replacement for a few years, or perhaps, prevent needing it at all if you do some of these things. And that's really the goal. A joint replacement surgery should be really a last resort, even though I think it's a great surgery. And then the one thing I want to hear really is that the pain from your arthritis is really limiting you from doing the things you want to do in life. And, commonly people will say, I can't play with my grandkids, I can't pick them up. When I walk with my partner, they leave me behind because I'm too slow, or I'm not doing the sports or exercise that I like to do. And so when your arthritis is limiting you from doing these things, that's when I say it's time to consider having joint replacement surgery. Now we've come a long way. Joint replacement surgery we've had the real benefit of having done millions and millions of these over the last few decades, and through decades of iterative improvement, we've really come a long way. So and I'll just talk about hip replacements, but the story about knee replacements is pretty similar. The first hip replacement, in the modern age, was done by Sir John Charnley in the 60s. And, he developed this low friction bearing surface using metal femoral stems, a polyethylene cup, and fixed these implants to bone using acrylic cement that was previously only used in dentistry. And, believe it or not, these fundamental concepts are still what we base a lot of the modern toe hip replacements on. So kind of just for fun, I found one of the early papers where I trained for fellowship on hip replacements, and the recovery back then was brutal. In the first week, you're in nearly a full body cast in bed. Between 2 and 3 weeks, you're suspended in this what looks like a torture device, and by week 6, you finally graduate to sitting in a hard chair. Really not what I think most people would sign up for these days. So in 2021, we've come a long way, and there's a number of reasons for that. Our implants have improved, our surgical techniques have improved, our rehab protocols have improved, and pain management with medications and the way we approach pain has improved dramatically, and also patient optimization, both before and after surgery. So Expectations today in hip replacement, and this is true of knee replacement too, immediately you're full weight bearing the day of surgery, which means if you have your hip or knee replacement tomorrow morning, then by tomorrow afternoon, we have you up and walking with our physical therapists and putting full weight on that leg, whether it's a hip or a knee. Typically, length of stay in the hospital is anywhere between 1 and 2 days. That's really just for physical therapy and pain control, but on average between 1 and 2 days. Average surgery time is about 90 minutes. So that's surgery time from my perspective, which is from when we make incision to when we close, 90 minutes. And that's an average. Some surgeries take less, maybe an hour, some take a little bit longer. We've really made a push for same-day discharge, or you may have heard of outpatient total joint replacement. And many institutions across the country are doing this, and UCI is too. And we're pretty selective about who we do it in. But whether you are discharged the same day, or if you leave the day after surgery or 2 days after, the goals don't change. The goals that we look for before you go home are safe, independent ambulation. So we have you work with physical therapists. They make sure that you can walk a safe number of steps on your own with a walker. And if you have stairs at home, they make sure you can walk that number of stairs before you go home. We want to make sure your pain is controlled on the medication that we send you home on, which means oral medication, nothing in the IV. And rarely these days does anyone go to a skilled nursing facility, which is a pretty big change from even, 5 or 10 years ago. I think patients prefer going home, and certainly after the age of COVID, I'm reluctant to send anyone to a skilled nursing facility unless we absolutely have to. A common question I get is, how long is recovery? And it's, I think people get frustrated when I give my answer, which is everyone's different, but it's true. If you're in your 50s and you run, a couple miles every other day versus if you're in your 80s or 90s and you walk with a walker at baseline, your recovery is going to be different. But I find it helpful to put it in terms of percentages. So I say, typically at 6 weeks, whether it's a hip or a knee replacement, you're about 60% recovered. So a month and a half, you're about 60% recovered. At 3 months, you're about 90% recovered. And at 1 year, you're about 100% recovered. You get that last 10% over the course of the year. And that's really your new baseline. And, after a year, I don't expect that, the muscles have recovered, everything is recovered. That should be your new normal. And, keeping in mind that starting the day of surgery, you're up and walking and putting full weight on the limb. So most people, I would say by about 3 weeks, they're ready to get rid of their assisted device, but that's also very, patient dependent. So what's new in the last decade? I think I touched on this a little bit. Our implants are, maybe not in the last decade, but certainly in the last several decades have changed dramatically. And this, we've learned from some mistakes, and most of the implants that are used commonly these days have the benefit of being time tested over several decades. So, what's in them? The stems are typically made of titanium. So the stem is the part of the implant that goes into the femur, shown right here. And the head is typically made of ceramic, most commonly ceramic these days, sometimes metal. The liner, which makes up the other part of the bearing surface, along with the head, is typically made of polyethylene. And the shell, or the cup, which is the part of the implant that is affixed to the pelvis, is typically made of titanium as well. If you ask someone 10 or 15 years ago about hip replacement, the common line was, hip replacement is, it only lasts 10 or 15 or 20 years. And that was largely because of the polyethylene liner. So this plastic liner, historically, before, about the year 2000 or so, we used conventional polyethylene. And starting in around the year 2000, we switched over to what's called highly cross-linked polyethylene. And to make a long story short, a lot of the issues that we see, with older hip replacements performed before the year 2000, with this particular plastic wearing out, we don't see anymore. So we now have 20 years of data on the new generation polyethylene, and the part of that implant wearing out is largely not a thing. For knee replacements, the femoral component is made of a cobalt chrome alloy. The liner between the femoral and tibial components that you can see here is again polyethylene, and the tibial base plate is made of titanium. These implants, at least in the US and mostly across the world too, for total knee replacements are fixed to bone using what we call cement, but it's really an acrylic polymer called polymethyl methacrylate. So that's what's new with implants now. Now moving on to hip replacement, if you've talked to anyone about hip replacement these days, they probably, have heard of, most people have heard of anterior versus posterior approach, and it can be very confusing, and there's a lot of conflicting data out there, and I'll try to clarify some of it. So, when we talk about anterior posterior approach, this is really, where the incision is on the body and the, what musculature we go through and tissues that we have to go through to get to the hip joint. So if you look on the left, the anterior approach is an incision based mostly on the front of the body. And the posterior approach is an incision based on, kind of the buttock area of the body. And traditionally hip replacements, for the last several decades were largely done through the posterior approach. So this is the traditional approach. Part of the approach is that we split the gluteus maximus fibers. We release and repair a set of muscles called the short external rotators, as well as the posterior hip capsule. And, this incision is pretty large, by today's standards. Certainly, I don't think people are doing incisions this large anymore, but this is where you would expect the incision to be. After surgery, typically, there are restrictions. You don't want your hip flexed past 90 degrees. You don't want any internal rotation, which is shown in the bottom right here, which just means in-toeing. And you don't want to really bring your leg past midline. And these are all the positions that put you at risk of your hip dislocating posteriorly. So these restrictions are usually for about 6 weeks after surgery. Patients sometimes, don't like these restrictions. So for anterior approach, I have to start by saying that much of what I think people hear is due to marketing, but a lot of it is based on evidence as well. So there's some evidence that suggests that there's a little bit faster recovery from the anterior approach. Here's where the incision would be for an anterior approach, and this is an example of some marketing for the anterior approach. But it's in a sense more muscle sparing. We don't split any muscles when we do the anterior approach. This, in theory, leads to a little bit less early pain. And, most people, I think, recover a little bit quicker with the anterior approach. There have been a lot of studies comparing the anterior and posterior approach. And, that's pretty clear that at 1 year after surgery, it doesn't matter if you've had the anterior or posterior approach. Most people have the same outcomes. But it's, the focus of anterior approach is really for the earlier recovery. And there's also some evidence that there's slightly decreased risk of instability with the anterior approach. So, which approach is better? We get this question a lot. I would say, really let the surgeon choose what approach that they're comfortable with, that they're experienced with, and you'll have a good outcome from a hip replacement either way. Again, most surgical techniques have become less invasive in the past decade, and there are some surgeons who feel comfortable without putting any restrictions on hip motion after even a posterior approach hip. So my personal opinion is that, my personal preference is the anterior approach. I don't typically put range of motion restrictions on my patients, and, anecdotally, I do feel like patients recover a little bit faster. And it's, as our population is more active at a younger age and, get to the point where they have joint replacements at a younger age, it makes a difference for recovery. So this is a picture of a couple of my patients. I don't know why I seem to attract bikers, but, the one on the left, I got a text message from his wife this past weekend saying, "Hey, did you clear him for this?" And, I said, I didn't clear him for this, but I also didn't explicitly forbid him from doing it. So, it's nice to see. It's nice to see people being this active after, a pretty large surgery. Robotics. So, robotics and computer navigated surgery have really come into vogue. I would say that, again, like with the anterior approach, I would say beware of the marketing. There's all kinds of ads. They say that this is a new solution for joint pain. This robot's going to take all your pain away. I don't, I think there's value in robotics and value in computer navigated surgery, but I think this is a little bit overdoing it. When people ask, is a robot doing my surgery? And they imagine, the doctor playing a computer game in the corner and the robot doing all the work. That's largely not the case. So the current state of robotics in total joint replacement is really, it looks like this. It's really a tool for the surgeon. We apply it to, the surgical field. There's different ways, different implant companies and different systems have, ways we can put trackers on the body, either through pins in the bone or by mapping out the bone. But largely the value in robotics and total joints currently is in planning. There isn't a whole lot, I think, that it adds in terms of doing the surgery, but it helps us align our guides and plan for, where we want to put the implants, how to align the limb, things like that. And this is, the bottom right is an example of this planning screen. And I don't use robotics for all my cases. I will use them for some of them. And I do think there's value in some cases. So, this is my opinion. I think there's little utility in having the robot come in and make the cuts for you, but there is utility in having the robot helping to plan the cuts in some cases. So in short, should knee replacements be done? Should all of them be done with robots? I think not yet. I think a good parallel to draw is, if you consider all new technologies when they were in their nascent stages, computers, cell phones, they're very niche to start. They don't have broad applicability, but at some point there comes a threshold where the value added makes it indispensable. And I think we will get there with robotics and joint replacements. But I certainly don't think we're there yet. But it's starting to become fairly promising. As an aside, most of this I was saying is for knee replacements. The utility of robotics and hip replacements, I think, is extremely limited. With imaging and with our current techniques, it just doesn't offer as much as it does for knee replacements. Partial knee replacement, who is a candidate? So, partial knee replacement is basically, instead of resurfacing the entire knee, so this is a diagram of that in the top left, where the entire femur is resurfaced with metal, and same with the tibia. A partial knee replacement or a unicompartmental knee replacement is when you only resurface one compartment. So for most people who have, we call varus arthritis, they have pain on the inside of their knee. If you have isolated arthritis in that area, then you're a candidate for a partial knee replacement. Historically, these were reserved for older, lower demand patients, but now the paradigm has really shifted, and it's a great solution for younger, more active patients. Patients in their 50s and 60s who have isolated medial compartment or lateral compartment arthritis. So why do it? It's in general, it's a faster recovery. It's a smaller surgery, smaller incision. Most people find, people who've had a full knee replacement versus a partial knee, they find that a partial knee replacement is more normal feeling, and that has a lot to do with the fact that we preserve a lot of the ligaments, a lot of the native tissues like the ACL and PCL, which we typically have to take for a full knee replacement. Some contraindications, meaning people who can't have a partial knee replacement. If you have extensive arthritis throughout your knee, if you have ligament compromise like a torn ACL or PCL, or if you have significant angular deformity that we can't fix with just a partial knee replacement. But it's a good option for a number of people. And perhaps where we've made the most improvement in the last few years is our understanding of pain and the way we approach pain management, both before and after surgery. So you've probably heard of multimodal pain therapy. This just means that, historically we would do the surgery and then give you, this top right picture shows a PCA, which means patient controlled anesthesia. And you just hit the button when you had pain and it just kind of inject you full of opioid medicine. And we've learned that that's perhaps not the best way to do it. A better way is to target the pain proactively through a number of medications. And this has really become standard across the nation. We'll use, non-steroidal anti-inflammatories, muscle relaxants, Tylenol, and nerve pain agents. And we use them all in conjunction with each other with the goal of controlling pain and minimizing the use of opioid medication, which we know is habit forming. There's a number of side effects, and, it's been very successful. When possible, we use spinal anesthesia, which means instead of you going to sleep fully and putting a breathing tube in your throat for the surgery, We give you a shot in the back, or our anesthesiologists give you a shot in the back. It numbs you from the waist down. We give you some medicine, you go to sleep, but you're not, your breathing doesn't need to be assisted. You don't have to have general anesthesia. And this is better for, you have less side effects after general anesthesia, or after this, compared to general anesthesia. And, lets us get you up and moving faster. It's become very routine for knee replacements to do peripheral nerve blocks, adductor canal blocks. These are all kind of early pain management modalities that help with the goal, which is to get you up and walking the day of surgery, and hopefully leaving hospital the day of or the day after surgery. And lastly, a few other questions I get: when can I drive? The things, most of the studies suggest somewhere around 8 weeks. The truth is, if you're off all opioid, you have to be off all opioid medication. But if you're off the medication and it's your left leg, then, when your reaction time is normal, then you can really drive again. I tell people, start in a parking lot, move your leg back and forth, make sure you can brake on time. If it's your right knee or hip, then probably somewhere on the order of 8 weeks. And this is the same guidelines, make sure that you can react, and you have to be off opioid medication. People ask about going through airports. I mean, we've, millions and millions of people have hip and knee replacements. So if you just, gone are the days where you need a card, or you need to show them your incision. You really just tell the TSA agents that you have a joint replacement. They'll wand you, and it's no longer an issue. Do I need physical therapy after surgery? For knee replacements, I say yes. And really, that's just to make sure that you're bending your knee. We don't want your knee to get stiff. For hip replacements, I generally say no. There are cases, if you're, for people who need a little bit of help, getting around the house, who need a little bit more work, then we will do physical therapy. But generally, walking is as much physical therapy as you need after hip replacement. Some hard stops, in the end, both of these surgeries are elective surgeries. So meaning you have the surgery when it's right for you, when it's right for your life, and when it's right for your health. So if there are things that we can change that make you a better candidate for surgery, that lower your risk of infection, things like that, then we do it before surgery. And that means generally, if you're smoking, then we have you quit smoking before surgery. If you're severely overweight, so we use body mass index as a cutoff. If you're over 40, then we put you, in our practice at UCI, we generally will have you meet with our dietitians. There's a great weight loss program at UCI that we'll have people, cooperate with, and we'll wait until you get to a healthy body weight that decreases the risk of surgery. Obviously, if there's any active infection, a tooth infection, urinary tract infection, skin infection, these all need to be resolved prior to surgery. If you have a systemic illness like uncontrolled diabetes, things that we can make better, if you can get your diabetes under control, these are all things that decrease the risk that we undertake with surgery. So these are things that are kind of a hard stop for most places if you go to have a joint replacement. So takeaways, number one, I think, is to prevent arthritis. So number one thing is to maintain a healthy weight, remain active, and do low impact exercises. And these are true both if you have arthritis and, if you have a joint replacement too. Maintaining a healthy weight is critical for joint health, and remaining active and keeping your muscles strong is, equally important. Other takeaways: not all joint pain is arthritis. We talked a lot about surgery and treatments for arthritis today, but not all joint pain is due to arthritis. So at UCI, this is a picture of our department. We have a very comprehensive team of orthopedic specialists. Literally any orthopedic issue, we have a specialist for. So, the strength of our department is that we can really find a person who's an expert at, whatever issue comes in. And, if anyone here has, any issues, has questions about surgery, I'm always happy to provide consultation to discuss if surgery is right for you or for anyone because sometimes it's not, and surgery is not right for everyone. So with that, I'll end this. Thank you very much. This is my email. Please feel free to email if you have any questions. If you want to share anything with me, I'm always happy to get emails. I have clinics in Orange, Tustin, Costa Mesa, Irvine. I'm happy to see any of you. Thank you.
Hey, thank you so much. It was so informative. I don't think I've ever know so much about knee and hip replacement as much as you do. So we have quite a lot of questions. And I'll start with the first one. I think the first question they have is, what is your opinion about nano knee procedure?
Yeah, sure. So I have to preface this by saying that, I'm not involved with Nano Knee. And most of what I know about it is from a kind of outside looking in. Um, my understanding of the Nano Knee is that it's a group of surgeons who have developed kind of a proprietary set of techniques and I think implants that they use. And for people who don't know, the Nano Knee is like a heavily marketed knee replacement in the Southern California area, I think. And as far as I can tell, there's nothing, that they do that's very different from what the standard of care is. If you're to get your knee surgery done at UCI, or if you go to Kaiser or, UCLA or any of these relatively high volume places, I've seen a few claims that I find hard to believe, claims like you're not going to have any pain. I think that it sounds a little irresponsible to make a claim like that. So, in short, I'm not involved with them, and I think I would just refer back to some of the earlier things I said, where be wary of marketing. But some of the claims they make, like you're walking immediately after surgery, things like that, are pretty standard. That's the standard of care for a joint replacement anywhere.
All right. The second question is about steroid injection. She mentions that she's been told that too many steroid injections will damage the joint, and the number you can get is limited. Is that a question? I think if it's limited.
In short, I think that's true. The concern with too many steroid injections is that it's not healthy for the cartilage. How to quantify that versus for someone who just absolutely does not want surgery, it's kind of a judgment call. But it's true. We know that if you've had repeated steroid injections, the cartilage tends to degenerate a little bit. And we generally won't do a steroid injection more frequently than about every 3 months. And honestly, some people have come in and have had 20 plus steroid injections, but most people get to a point after 2 or 3 or 4 where they're like, the last one only lasted for a week. I don't think the next one's going to be that effective. And that generally is the case. And in which case we just consider that, that treatment option is kind of off the table.
The next question is, how can you determine if hip pain is related to arthritis or a bursal inflammation?
Yeah, that's sorry, what was the second half? If it's
bursal
related?
Inflammation. If it's related, how do you determine if hip pain is related to arthritis or bursal inflammation?
Yeah, that's a great question. I mean, obviously if you see a specialist, or if you see generally a primary care doctor too, they can tell you. But by and large, arthritis pain presents as pain in the groin. So most people will point directly to their groin or into the buttock and say, I have pain here. And it's generally with weight-bearing activity. So they'll say, I'm fine when I'm laying down, I'm fine at night, but when I get up and walk, it hurts. When I go up and down stairs, it hurts. And as opposed to bursal inflammation, so common bursa that gets inflamed is the trochanteric bursa. So this is out on the side of the hip. And typically if you have bursal inflammation, you can find a spot on the side of the hip that hurts when you push, as opposed to arthritic pain, where there's really no spot you can push with your finger typically that makes it hurt, but it'll hurt with walking and it'll hurt with certain positions. If you bring your knee to your chest, if you turn your foot in and out, that kind of thing is more suggestive of arthritis pain.
Well, I mean, I'm pretty young, so is there an age specific to when you can get pain on your hip and knee?
No, I mean, hip and knee pain are common. They're probably as common in younger people as they are in older people. But generally speaking, if you have hip or knee pain and you're younger than, let's say, 40, it's probably not end stage arthritis. There's a number of reasons you can have hip or knee pain that aren't arthritis. Just some off the top of my head, in the knee, you can have meniscal tears, you can have ACL tears, could be a fracture, could be a number of things. In the hip, you can have a labral tear, things like that. So that's kind of, it highlights the importance of, having someone evaluate you, get the appropriate imaging and the appropriate, diagnosis.
So the next question is there a chance that leg length will change?
Yeah, so that's a good question too. So this is generally, so for knee replacements, that's very rare. This is generally for hip replacements. And, historically, the way I was taught and the way I talk to patients about hip replacement is there are three goals, and it's in order of importance. The first goal is stability of the implants, meaning when we put the acetabular shell in and when we put the femoral component in, that these implants stick to your bone. That's the most important thing. The second most important thing is hip stability, meaning we don't want your hip to dislocate. And the third most important thing is restoration of your normal body mechanics, meaning your leg lengths, the muscle tension, things like that. And in order to obtain, some of the more important things, sometimes we sacrifice the less important things. So in this example would be, in order to achieve stability of the hip joint, there have been times where we have to lengthen the leg or increase the width of the hip. And, I would argue that this was with older surgical techniques, and I don't want to say older, but perhaps with previous surgical techniques, when we really struggled with stability of the hip, there were times when we would have to lengthen the leg and get the leg stable, or to get the hip stable. Nowadays, and for the vast majority of hip replacements that I do, we shoot to equalize the limb lengths. So oftentimes people will come in with bad arthritis and they'll be a centimeter or two short on, the arthritic side. We shoot to lengthen you back to equal. And rarely do we have to lengthen you more than that. So the short answer is yes. The longer answer is yes, but it rarely happens these days.
Wow. So the next one is about pain. So she's asking if turmeric extract help alleviate arthritic knee pain.
Yeah, so there's a lot of interesting
Or
research
alternative.
on turmeric and its anti-inflammatory abilities. I'm certainly not an expert in all of the literature, but if I were to synthesize it, I would put it in the same category as all the other alternative medicines, which is there's very little harm in it. And, if it helps you, it's worth a shot. I don't think that I would tell everyone you should take turmeric, you should take chondroitin and glucosamine, you should take all these things, because honestly, for the vast majority of people, it may not help. It probably doesn't, but if it helps you, I have no problem with any of my patients doing that.
I think another question is how long do total knee replacements typically last for someone who's in their late 50s? Quite a detail, like down to 2 millimeter of cartilage, still kind of actively playing sports.
Yeah. So, the data is mixed, and some of this is hard to judge because, like as with the hip, where we've been incrementally and kind of systematically improving techniques and the technologies. A total hip today, is going to last a lot longer than a total hip implanted, I think, 20 years ago. But if you want the data, the most recent data is that at about 20 years, and these are large database studies from national registries, in countries where they collect all this data. At 20 years, it's about 85% survivorship, meaning 85% of all total knees that are done at 20 years are still functioning without needing to be revised, having had another surgery. There are outliers. There are certainly people who need earlier revision, and there are people who go much longer not needing revision.
Another one is, are double knee replacements very common, and is that something that you would advise to do it at the same time?
Yeah, so I think they're asking about, having both knee replacements done in the same surgical setting. It's done, I've done it before. I usually try to talk people out of it. It's for a number of reasons. So rehab is a little bit harder. You have two limbs that you're rehabbing at the same time. And, it's typically, it makes that more challenging. Also, if you look at the risks involved with anesthesia, with the surgical event, if the risks are more than cumulative, if you do both knees in the same setting, meaning if, X percentage is your risk with one knee replacement, you would think that 2X would be the risk if you do both in the same setting. It actually ends up being a little bit higher than that. So generally what I recommend is you do whichever one hurts you more. And then once you're recovered and that knee is now your good knee, that you put more weight on that knee, then we do the other one. That usually is around 3 months after, after the first surgery. Having said that, there are extenuating circumstances. Some people who, for example, absolutely cannot take time off work twice, or, for whatever reason have life situation where this 3-month window is the only time they'll have to recover, then, sometimes we'll do it. But if you have the opportunity to stage your knee replacements, I generally recommend that.
Another question is, does the presence of osteoporosis influence surgery decision?
By and large, no. I think there's, people think osteoarthritis and osteoporosis and think that they're correlated. Generally, no. So osteoporosis is weakening of the bones and the bone quality. And this generally happens as we get older with age. It generally happens if you have a deficiency in vitamin D and calcium, which we all do for the most part. And it generally happens, unfortunately, in postmenopausal women for hormonal reasons. But, as it pertains to hip or knee replacement surgery, it affects some of the surgical choices we make in terms of implants. So if someone has very, osteoporotic bone and we're doing a hip replacement, then instead of using uncemented implants, we will sometimes use cemented implants. For knees, we usually cement regardless. There are uncemented knees, but most knees, regardless of bone quality these days, are cemented. So the distinction isn't as great there. So the short answer is yes, it changes some of our techniques, but for your outcome, for the patient's outcome and what you experience after having the surgery, there really is no difference.
And this is our last question. Are you using or growing a meniscus for a spot replacement of a frayed meniscus?
Sorry, can you repeat that?
It says, are you using or growing a meniscus for a spot replacement of a frayed meniscus? So I think it's about meniscus.
Yeah, this sounds like a question about meniscal transplant or,
yes.
Something like that. Meniscal transplant is a surgery that exists. It's very rare. It's usually reserved for, any meniscal surgery that you have, whether it's debridement, repair, in the setting of arthritis is sort of doomed to failure. We know this from large studies and years of experience, meaning, people will often show up and they'll get an MRI from their primary care doctor and it'll say, oh, you have a meniscus tear and, you have some arthritis. But really, if you think of arthritis as a spectrum of disease, where on the one end you have, end stage, bone on bone, you're ready for surgery. All the way on the other side of the spectrum, the very early signs of arthritis are actually, they present as meniscal tears. These are tears that are degenerative changes in the meniscus. It's not like a 25-year-old NBA athlete who lands wrong and tears the meniscus. It's more like the ends of a rug that kind of get frayed over time. And those types of tears are, we call degenerative tears. And those typically don't respond well to surgical repair or debridement. So in short, if you have any evidence of arthritis, meaning degeneration in the knee joint, the knee is generally considered too far gone for any meniscal transplant. In cases where the cartilage is pristine, everything's perfect. And generally this is in younger patients in their teens, 20s. And the issue is the meniscus. Our sports surgeons will sometimes do meniscal transplants. Yes.
Well, that's the last question. And I think Michelle Duran, I think from UCI Health, said if you are interested in scheduling an appointment with Dr. Yang, to please call 714-456-7012 or email Dr. Yang. There is an email on the slideshow. So I think this is all for today. Thank you, Dr. Yang and UCI Health for this informative event. I think I've learned so much about knee and hip replacement. And I want to remind everyone that the program is recorded and will be available to watch on Library Foundation's YouTube channel and our website. And thank you all for attending our virtual event.
Thank you. Thanks for having me.